nothing to disclose. So innovative approaches to improving care to the use of these bundles. I will try to give you some history from where it is started, theory of change, then how to design, what are the outcomes, reflection and suggestion for the further research. Now, learning together to improve care is the main theme nowadays. We cannot do individualized approach, so that's why we have to share our knowledge and our practices depending on the evidence base. So this is the stratification or the ladder model of that learn, then measure it, then improve, and then share with your experience. And this is the main model we are going to apply now or implement in our practices. So what is the improvement formula? The formula is simple: generalizable scientific evidence, then you have to choose the particular context according to your patient and practices, and then you have to perform improvement project or measure your performance. So what to do is evidence-based medicine, and how to do is evidence-based practice. So we will further elaborate on that. So this is the improvement formula nowadays implemented in many of the hospitals. It is published in 13 years ago by Dr. Betteldine and David Off. So what is the definition of bundle? What do you think, what do you mean by the bundle of the care, or what is the bundle? So it's a small set of evidence-based intervention for a defined patient segment population and a care setting that when implemented together will result in significantly better outcome than when implemented individually. So if you do any process individually, the outcome cannot be that robust or that good as if you try to do a combination of a few processes. So, and it has to be targeted about some population or some patient segment. Now, some of the history that the first time the bundle was introduced by Institute of Healthcare Improvement in USA in collaboration with Voluntary Hospital Association, VHA. It's a joint initiative, and they want to idealize design of the ICUs. So of course the critical care is the critical care, and it has to be very focused treatment there. So they involved 13 hospitals, and the goal of the initiative was to improve the level of the critical care, the reliability of that, and then they measure the outcome. The theory was that enhancing the teamwork and communication, and they focus on the areas potential for the great harm and high cost, and where the evidence base was strong. So as you know, as the old Hippocratic Oath, that first do no harm. So everything based on that Hippocratic Oath. The first two bundle designed and published by those two associations is the central line bundle, which we call CLAPSI bundle, and the ventilator bundle, which we call the VAP, ventilator associated ammonia bundle. And you all know those components of those bundle. For example, hand hygiene in central line bundle, maximum barrier precaution, chlorhexidine, optimal catheter site selection, daily review of the line necessity, and so on and so forth. The measurement and the implementation of that bundle is going to be on the basis of all or none measurement. All or none means, as we learn from the physiology, either the muscle contract fully or the muscle will not contract. So this is the all or none process. So whatever the variables in your bundle, you have to implement all of them, unless and until some medical contraindication to that. So again, this is the same formula, generalized scientific evidence, particular context according to your patient, and then you have to improve your by measuring your performance. Initially, when they designed those bundles in IDICU, Idealized Design ICU initiative, they found it out that only 10 to 20% compliance at the best. So increase to or to motivate to change processes, it takes some time, and it is really very important to understand that these type of change really brings the good and excellent outcome. So how they initially did, they focus on the teamwork and the communication, and this is the another great topic on talk about the teamwork and communication. But for this talk, I just want to mention about or emphasize on that of course the teamwork and the communication is the main thing to ensure the great outcomes of the patient. So the focus on teamwork and communication in ensuring reliable and consistent care to improve the compliance rates ensured. So high level of compliance with the central line bundle decrease collapses. So what they find it out when they educate, when they get the permission of the team, and when they communicate it very nicely, then it is the high level of the compliance that they achieve, and they find it out that it is the rate of the collapse in that particular situation is reduced. And if I'm now currently attached with the Mayo Clinic, they all also have the 5 safe behavior in under the umbrella of first do no harm. And one of them is the proper communication, proper handover, and proper teamwork. So what is the element of the success? First, in both cases, participating clinicians should agree, the all other teams should agree, and it should implement it accordingly. And the second is the list of elements included in the bundle was short, not more than 5. So the reason is that if you have a guidelines of pages and pages of 17 page, 18 page, nobody is going to read it when the frontliners or the doctors or the physician or the nurses want to use them. So it has to be concise. So that's why the idea of algorithms comes, idea of pathways come, that in this time you have to do that much treatment or that in a very short and nice way. So this bundle should not include more than 5 steps. Of course, the message, what we are trying to learn, that bundles are not intended to comprehensive care when the compliance is a measure for a core set of accepted elements of the care for clinical process. And the most importantly, the necessary teamwork and cooperation required will result in the high level of sustained performance, not observed when working to improve individual elements. And this is the very important message learned from this exercise. Now, there's some data from 2018 in article of critical care and shock presented ventilator bundle compliance report from a neurosurgical intensive care unit, and you can imagine the acuity of that unit, neurosurgical intensive care unit, is very, very high. And what they find it out, the pre-educational compliance and the post-educational compliance. And what they conclude that a simple education strategy can improve compliance of the ventilator bundle. This in turn, and although not demonstrate, can subsequently affect the mortality of the patient. Collaborative work between team members of the unit is the key of the compliance. So all the p-values are in favor of those after the post-educational compliance, the compliance increase. And as you know, as I said in my previous slide, if the compliance increase, the chances of the outcome towards better is very, very high. So theory of the change, why do bundle produce better outcomes? Bundle change the assumptions that evidence-based care is being delivered reliably. Reliable means that if you are doing some test repeatedly, it should show the same result. So it means that that test is reliable for that particular variable which you are doing for. So reliability is a very important issue. Then bundle promotes awareness that entire care team must work together, and it is very important. So for example, if you are at your senior level, at the high at the professor level, you are doing the rounds, you might have some different management than in the afternoon when the fellows are out, in the night when the residents are taking over. So to combine the efforts and to make a standardized approach to the patient is a very important aspect of that. Bundle promotes the use of improvement methods to redesign care processes. So one by one, if you take it, so bundle changes the assumption that evidence-based care is being delivered reliably. So if you have 5 elements and let's say 90% reliability is there, then the 5 times 90%, which is a very high reliability on that. And typically most clinicians assume that the bundle elements are being reliable perform on their patients. However, when they collect their initial data, they are often surprised at the low level of all or none bundle compliance, with some ICU findings reliability levels of 10 to 20%. So that's the issue of the compliance, that if you comply to that, your bundle of care, your results will be very good. Then bundle promote the awareness that the entire care team must work together. So as I said, teams that have achieved high levels of compliance and concomitant improve outcome did so through working as a team in new ways. So using specific daily goals developed by the team and the patient, multidisciplinary round, debriefs, handoffs at the end of the day to reflect on compliance and to plan ongoing improvement. The third one is bundle promote the use of improvement method to redesign care process. And there are other model for improvements, like for example, what are we trying to accomplish? How will we know the change in the improvement, and what change can we make that will result in improvement? And then we do PDSA, the plan, do, study, act. So the theoretical step in developing a care bundle, it identifies the critical care theme. So whatever the critical or acute things happening in your unit, you should identify that. Then identify a cluster of intervention practices within the theme. So you must doing something individually. If you combine all these together, that's a much better approach to, or much standardized approach to the patient. Then, of course, you'll search the literature. After searching, I always said the research the literature, then categorize the available research according to its quality, and delete any intervention practices from your list that do not have an adequate evidence. On the basis of analyzed research evidence, develop evidence-based intervention. So that's how you will reach the excellence of care in your unit. So how you can design a bundle? So this is the bundle design guidelines. The bundle has 3 to 5 interventions. Each bundle element is relatively independent. The bundle is used with a defined patient population. Multidisciplinary care team develops the bundle. Bundle element should be descriptive rather than perspective to allow for a local customization, and compliance when the bundle is measured using all or none measurement with the goal to touch about 95%. So the first element, the bundle has 3 to 5 intervention with a strong clinical agreement. So it is already recommended that they are generally accepted in national guidelines and by local consensus of clinicians as being appropriate care for the population of the focus. So the goal of the bundle approach is to pull together those 5 elements and to apply when they need it. And it can include only those elements that most clinicians accept applicably to most patients in the populations, allow the team to move forward with improvement rather than spend time debating the validity of the elements. If you have more than 5 or 6 elements, it becomes mathematically more difficult to achieve high compliance with all or none measure. So it is recommended that when you develop any bundle, just limit it to 3 to 5 interventions. Since the intent is neither to create a comprehensive care protocol nor to include elements that vary in the applicability to individual patient, using 3 to 5 element is most successful. The second is each bundle element is relatively independent. So the bundle is designed so that if one of the element cannot be implemented for some reason, it will not affect the whole 5 steps. So for example, in the center line bundle, if the center line insertion site was not cleansed with the chlorhexidine due to any reason, the remaining 4 center line bundle elements should be implemented. So it has to be individualized. The bundle is used with the defined patient population. So of course, the population you are using, so we are working in NICU with a very premature baby, so our population is different. In the surgical unit, that's different in the PICU or the any other adult ICU. So we have to design the bundles in consideration of our population, which is very young and newborns and most of the time the premature babies. Of course, this is the key that the multidisciplinary care team develops the bundle, and communication and communication and communication among all participants and all stakeholders should be essential. The bundle elements should be descriptive rather than prescriptive, and I told you why. So we put the one example that you should just put it, for example, the DVT and the peptic ulcer disease prophylaxis element. You just put this element. You don't have to specify which medicine or which this thing they can be do accordingly. So for example, if you want to have a neonatal sepsis bundle, we cannot suggest any antibiotics because each NICU bacteria level is different. So if I working in a mid-income countries where the gram-negative is very common as compared to, so I cannot suggest the same kind of antibiotics to those units. Local clinician will determine the appropriate form of their patient population, so they know their patient population very well and they can modify it. All exceptions should be documented. This is very important. So we just heard Dr. Hussam talking about the importance of medical records, electronic medical records. So any deviation from the standards which you make for your own unit, if you deviate from that, you should document that why it is a document. So the person who's taking over in the evening, in the night, they know that that's why they deviate from the standard of cares. Now, the compliance with the bundles measured using all or none measurement with a goal of 95% is not that easy. But if you do the proper education and proper training for that, you can. The compliance with bundle is measured by documentation adherence. There is a simple checklist, yes or no, you can mark it on, and then you can do it. As I said before, there is no partial credit is given. If it is something missing for no reason, then it is not completed as a bundle care. The percentage of all or non-compliance for a bundle always focuses on a patient population. Example, the percentage of patients on ventilators in the ICU who receive bundle elements or had documentation contraindication. So the compliance is very important. Now, this is the example of the compliance is from the Center of Disease Control and Prevention National Health Safety Network in 2019, 2018, they published it. Look at these two lines. So the first line, which is, I don't know which color you are seeing, but in my screen it's a blue, which is the ventilator-associated pneumonia VAP rate, and the green, which is the VAP bundle compliance. So as you can see, forgot about the variable, I come to that, but as you can see, the use of the bundle increase, the incidence rate of the VAP is coming down. Of course, there is some spikes, but look at that. It is very positive correlation between two. Now, if you see that web bundle started here, then implementation of that, and then minimum of 10 patients audited each month. And as so long as they are auditing and their compliance is good, is increasing, the rate of the VAT is decreasing. So it's a very positive correlation. To make it easy and very simple, this is the total bundle compliance, and this is the number of the VAPs. So in January 2012 is zero VAP when there is a 90% compliance. There's a 94% compliance, but they have a one VAP. It can be possible. But look at that. When they drop to 88, the VAP increased to the 3 in that National Health Safety Network. So it is a positive correlation between the implementation of the bundles and the compliance. Again, in 2018, International Journal of Applied Research also published that the practice score was classified as adequate and inadequate practices. It was observed that care bundle adequate practice was 85% and inadequate practice was 15%. And they found it out that in conclusion, compliance with the standard of the care bundles was relatively acceptable. So the compliance, the people want to comply with that bundle. There's another study in May 2019. This is the change in the crude mortality, then change in the length of stay, and preoperative antibiotic use. And as you can see, in all parameters, it is really a drop in those variables when they apply the standard of care and the bundle of the care. So the significant improvement in recognized quality standard of care were achieved by using the evidence-based care bundles. So it is really very evident now that if you imply or if you have compliant with your bundles, you can have a very good outcome. Overall, it is published in 2019 in Implementation Science, the effect of care bundles on patient outcome, a systematic review and meta-analysis. You cannot see it's a very busy slide. A lot of studies all go in the favor of the care bundle as compared to the favors of usual care. So all in the favor of it, make it easy. I divided it into the different variables, but as you can see, all the diamonds in favor of the bundle of the care. Now, it is very important. Nurses is the most important integral part of our healthcare system. And this is the published in, again, 2019 in International Emergency Nursing. And they want to find it out, the nurses' perceptions of using an evidence-based care bundle for initial emergency nursing management of patients with severe traumatic brain injury. Again, the acuity is very high. It's emergency nurses with a severe traumatic brain injury, they are receiving the patient. It is this study done in the Thailand. And what they found it out, that Thai emergency nurses perceived that using the care bundle helped them to improve the quality of care as a result of increased knowledge, skill, and confidence. A care bundle approach is an acceptable strategy to increase integration of research evidence into the context and facilitate emergency nurses to deliver optimum care to the patient. So this is one of the examples, but I think it is fit to all in intensive care, in NICUs, where we have a very sick population of the patients. So to finish with off, back to the start, J.L. Vincent said, one size most certainly does not fit all. So why bother to have a guidelines and a standardized approach and bundles? It is not true because they work. As I showed you the evidence, as I showed you the studies, that the bundle of the cares is work because they have been shown to work in terms of improved outcome. So, but for the reason outlined at this stage, at the start, improve multidisciplinary care, better, more efficient team working, and realization that the problem is access. Care bundles are an excellent idea and should be our aim to ensure all our patients are managed appropriately and aggressively, reducing organ failure, reducing mortality, especially if you are working in the intensive care environment. No care bundle for an area as a diverse as sepsis management will ever be perfect. Creating a set of broadly applicable intervention to consider in all patients all the time is very, very important. So a bundle can bring together these ideas, crystallize them into a small set of bullets, allow wide dissemination to allow those caring for a defined patient group, allow realization that intervention early will improve mortality. So as you know, in our field, the golden hour, the golden minute. So if you have the bundle of the care that you have to provide antibiotic within 1 hour, you have to complete that set of the problem in that certain time, it definitely improve your outcome in terms of morbidity and mortality. In my previous workplace, we implemented the bundle of the care of IVH, and we get a very good results. I'm collecting on it. The data is still, and we will publish it. Establish and reinforce application of the best practice. So my take-home message, to ensure optimal support from the clinician, bundle developer should always remember to select elements that are supported by the evidence. It is worth reiterating that a bundle itself does not improve care, rather improvement is a result of the strategy taken by the team to redesign, work, communicate better, and work more effectively towards achieving patient goals. It is important for future bundle to be tested since not all clinical topics lend themselves to this approach. Remember, I told you the old Hippocratic Oath, first do no harm, but there is a new oath also, and they said that I will apply for the benefit of the sick. All measures are required, avoiding those twin traps of overtreatment and therapeutic nihilism. So the meaning of that, sometimes we are thinking that, oh, we are doing very good to the patient. In fact, not. We are overtreating it. And therapeutic nihilism means that our false beliefs about some kind of a treatment. For example, yesterday we discussed about how that we are prolonging the antibiotic treatment more than 7 days and 10 days. And all the evidence suggests now that it is not needed. So this is the new Hippocratic Oath. You should combine with the first do no harm. My last slide to remind you the same quote, medicine is the marriage of science and art. What you know is the science, and all of you are much more knowledgeable, but how you apply it reliably and effectively is an art. And we shouldn't break this marriage of science and art. With that, I will close my talk.
Now we're going to have a panel discussion. We have a lot of questions coming our way, and we keep receiving questions as we go into the interactive session of question and answers. The first question will be for Dr. Hussam. Dr. Hussam, we have a question about electronic documentation is more time consuming than paper documentation, which lead to less time spent in patient interaction with patients. How can we balance this with the benefits of electronic documentation?
Yeah, so thank you so much for the question, Aiman, and for the asking party. So the clinical documentation is very, very wide topic. We can talk about it for hours and hours. However, this was my favorite topic to deal with. The physician documentation in particular needs a lot of standardization. We know for a fact that worldwide, the standardization for physician documentation did not exist for years and years. And this has led to a lot of confusion with the data and the document retrieval. Again, go with that paradigm, garbage in, garbage out. I'm sorry, but the thing is, we invest a lot of time to document something is not agreed upon as standards to be used, and we may opt also to make use of the free text, the copy-paste functionality of the clinical documentation, physician documentation in particular. This has led to a lot of confusion. So the short answer, because of lack of standardization with the physician documentation, this might be one of the end results, and the dissatisfaction of physicians with this, we do documents in the electronic health trackers. So I would say having a couple of standardized templates would greatly help. So some of them are disease-oriented, some of them the service-oriented, procedure-oriented, this kind of thing.
Great, thank you very much, Dr. Sam. The next question for Dr. Dayal. We have actually a lot of questions for you, but I will just try to break them down. When to start the treatment for clubfoot, and how early can we start the treatment or recognizing the problem in a premature infant of a clubfoot in premature infant?
Yeah, those are great questions. So the ideal time to start treatment for clubfoot is actually when the infant is less than 2 months old. And that's because their foot is very supple, their bones haven't ossified yet, and it's more easy to pliable to move the different positions. And then actually for the second question is sometimes you can actually notice this in utero in ultrasounds. So it's a great way to at least discuss this with the parents on what to expect when coming out. Sometimes you notice it on a prenatal ultrasound and then in reality the foot is fine. There are other times when just from being in the womb and squished, the foot looks like it is a clubfoot, but if you can move it back, then it's totally normal. The biggest thing is after they're born, if it's stuck in this position, then that's considered a clubfoot, and to seek treatment as soon as possible.
Very good, thank you. Next question, Dr. Junaid.
Yes.
How we should enforce bundle in the real time, not into retrospective audit? How do we have somebody who watch and can stop the procedure if we violate the bundle, or should we just do retrospective audit?
That is actually a very good question and a little bit difficult on it. It depends on the emergency you are. As I showed you one study from the Thailand where they received the brain injury patient, and all of them, the nurse's perspective is that they can apply those bundles right away, and it's not any problem. So I think that it needs more education and the teamwork. It's like a pause that one is the course, one is the team leader, and then you are running the code. So it's like, or the NRB. So it's like that if you have a complete checklist and if you know the bundle of care you have to apply, you can do that. For example, we had in my previous hospital is the IVH bundle of the care. So as soon as 24, 25 weeks are born, we started from that. It includes like dimming of the lights and the sound protection and all those things, and to put it in the straight line head and something like that. So we started from that point. Yes. Sometimes you are not that accurate, but that's how we said that if you implemented 90% compliant with the bundle, you are doing okay.
Very good, thank you. Dr. Hussam, you listed a lot of advantages to using electronic medical records. Can you list some of the disadvantages of using electronic health informatics?
Of course. Actually, this one I deleted.
This is not from me. This is from the audience.
No, I like the point because I deleted deliberately the couple of slides from the presentation talking about those risks and pitfalls. So certainly this would medication errors, and we come across it in every day, that medication errors because of the while ordering. So again, some of them are user tech as a lack of proper training. Another would be system design issues, and the defaulting medications, doses, routes, etc. These kind of things. And so the other thing is the copy paste, which is we all know that functionality and how bad this might end up having. I remember one of the cases I came across was like one of the documentation was a baby in critical condition, NPO, exam normal, feeding well, and for the charge. This was because of copy paste functionality, and we all know it's worldwide. It's not something. So unless we pay a lot of attention, again, I'll go back to the point of the system design or the targeted benefits first. This would be translated into a couple of targeted benefits at the organization, facility, service, etc. And because of that, some standardization, and again, the proper training for all the practitioners, this would lead definitely to minimizing those kind of risks, which is very, very, very important. So thank you for the question.
Okay. Thank you, Dr. Sam. So next question actually is very technical. I'm sure I'm going to say the name of the participant who asked it because I think he is an orthopedic surgeon, Dr. Sabir Khan Khaybar from Teaching Hospital, Peshawar, Pakistan. I know Dr. Junaid, ring a bell.
Yeah.
So this is for Dr. Dayal. Till what age Ponseti method is recommended, and beyond which age surgical method is
the question is, Dr. Aiman is, I think, the sound is a problem. So, Dr. Dayal, the question is that
we broke up. This is for Dr. Dayal. Can you hear us?
Can you repeat it again, Aiman?
Okay. So the question, Dr. Dayal, till what age Ponseti method is recommended, and beyond which age surgical method is recommended?
Yeah, that's a great question. So I think, you know, the Ponseti method is recommended as soon as possible, but there are in some countries where they have attempted to do the Ponseti method, you know, when children are greater than 1 year old. It's more likely the longer you wait to get treatment, the more likely you'll need a surgical technique because it's very hard to manipulate the foot and the bones and the tendons are already set. So it's a difficult question.
Okay. Next question also for Dr. Dayal. I don't know if you can hear me okay, because we are kind of breaking up a little bit. So the question is, after completion of weekly serial plasters casting, which type of shoes or braces and physical exercise do you recommend, and for how long you maintain and further improve the correct position?
That's a great question. This is actually very central to clubfoot treatment. So the serial casting is almost 2 months. And then what happens after that is we place the child in shoes that set the foot, that keep it set there. And it's attached to both feet. And they wear this bar almost 24 hours a day up until they're 2 years old. And the reason we do that is so there isn't any relapse or recurrence of the clubfoot. So there's, you know, there are many different types of bars out there, and there are some very low cost ones as well that are very helpful in global health situations. And that's actually the key, is to make sure that the parents keep them in that position for up to 2 years old.
Okay, great. Thank you. Next question, Dr. Hussam. We know that, you know, when we have data designed for all ages, it makes sometimes customization of data for specific ages or certain diseases difficult. what's your recommendation of how we customize the data for its use for the neonatal population, not for the general hospital population?
Right. So again, the systems are quite smart, and you can categorize data according to the age group. This depends on the, again, the data model and registry and the data repository you design first place while designing the system in. So it depends, again, what sort of organization. Again, those kind of decisions are at the organization level, not facility level. Because at the end of the day, just I'll take the example of Saha, for example, that we need to know what's happening at the neonatal service across different Saha facilities. So there must be some sort of design decisions taken at the organization level to make that categorization of data. If I'm aiming that first place before and at the design phase of the system implementation.
Great. Thank you very much. And thank you for all the speakers for great presentations and great sessions. We're gonna have some more questions. I'm sure they're coming through, and we will send them to you as they come through. So hopefully we have your email so we can send it to you.
So
I appreciate your time, and thank you very much for being with us. I appreciate everybody's time, and thank you very much. That will conclude the session for the morning.
So I have questions. Remember with the presentation I had about the which system, whether the system are vendor specific or vendor neutral, and other one, what is the best system to adopt. So I'm not sure if anyone was, shared the answers of those questions, but probably for sake of time. So those kind of system, the best system is that system comply with my needs. This is the best system ever. So it's not something towards any of the vendors. The second thing, the transformation process is vendor neutral. So a lot of vendors keep saying, we provide whatever training because this is important for you. The best system is my system that fulfills my requirement, and it's vendor neutral. So thank you again, and very much appreciate it.
So
great.
Thank you very much. Thank you, Dr. Aiman. The next session will start in 15 minutes. To all the participants who join, it's a session, very comprehensive session on neonatal endocrinology from the Children's Hospital of Philadelphia.